Dr. Urvashi, good afternoon, ma'am.
Good afternoon, everyone. Thank you for this invite and the meeting.
Good afternoon. Shall we start the clinic now?
Yes, please.
Yeah, thank you. Very good afternoon, everyone. It is my pleasure to welcome you all to the 4th Pediatric TB Eco Clinic in collaboration with the Regional Pediatric Center of Excellence for Tuberculosis. This clinic is dedicated to the challenging cases which we face on day-to-day basis in pediatric tuberculosis. Tuberculosis, as we all know, is still the most pressing global health issue, and especially when it comes to children, the complexities increases in terms of diagnosis and treating the patients. On behalf of NITRD, let me extend my warm greetings to our DDG TB, Central TB Division, Professor Urvashi B. Singh, ma'am, and her team. She has recently been appointed as the Deputy Director General of Tuberculosis. She is a distinguished medical microbiologist at AIIMS, Delhi, and has extensive research work in the field of tuberculosis. Her leadership and expertise will surely help us to continue to confront the global burden of pediatric tuberculosis. Welcome you, ma'am. I welcome directors and team from NIITs, NTIs, STOs, Faculty of Medical Colleges, district TB officers, TB pediatricians, and everyone who is attending today's clinic. So let me introduce the faculty from NITRD. I'm Dr. Saroj Meena, chest specialist at NITRD, and will be moderating today's session. To my right is Dr. Neeta Singla, ma'am. She is nodal officer for conduct of eco clinics at NITRD. And to my left is Dr. Alok Yadav. He is a pediatrician and CMO NFSC at NITRD. Now I request our director, ma'am, Dr. Manpreet Bhalla, ma'am, to please give your inaugural address.
Thank you, Dr. Saroj. Good afternoon and welcome once again for another session of Pediatric TB Eco Clinic, which is being held in collaboration with the Regional Pediatric Center of Excellence for Tuberculosis. I extend a warm welcome to Dr. Urvashi Singh, DDG TB, and the experts for today's session, Professor Kamal Kumar Singhal and Professor Varinder Singh, and all the other participants who have joined today. So today's session is on diagnostic dilemma in probable cases of pediatric DRTB. So as we all are aware that pediatric TB is a very challenging to diagnose as well as treat, especially for extrapulmonary TB, and because it's very difficult to get the samples from children. So this we need to address this whether it is drug sensitive TB or drug resistant TB. So we face a diagnostic challenge and a dilemma. So this is these sessions are very important, and we need to hold these sessions, and that is why we are having these pediatric TB eco clinics for diagnosis as well as treatment. So I just wish you all the best for today's session. Thank you. Thank you.
Thank you, ma'am. Now I request Professor Urvashi, ma'am, please give your address for the clinic. Address the clinic.
Good afternoon, the hosts, the director NITRD, and all the participants. So thank you for the continued eco discussions that you've been organizing. Dr. Neeta Singla, I must congratulate you for the hard work you put behind selecting the right cases and discussing them at length. Coming back to what Dr. Manpreet had said earlier, pediatric and extrapulmonary tuberculosis are two areas where not only diagnosis as well as the treatment is difficult. We are having an EPTB workshop at Bangalore for 5 days where we are further refining our training tools and the guidelines for EPTB under the programmatic conditions. So I would like to reiterate that we are all aware that diagnosis is difficult despite the newer nucleic acid amplification tests. It is primarily because in children, it may not always be, the airway disease. There could be intrathoracic disease, which is not really reflecting into there may be no cavitation, or if when there's cavitation, it may not be communicating to the airways. So hence, the airway samples may not always be representative of the pulmonary TB disease in children. Then we have predominance of lymph node TB and other extrapulmonary TB as well in children. So of course, while science works at designing newer diagnostics to help us out where our current diagnostics do not help, we must make the most of what we have. So there are some published work using urine lamb in pediatric TB, but of course we are in the process of validating it under the programmatic conditions. If that proves to be helpful under programmatic conditions. So we are currently, I think the today's case will highlight as to how the diagnoses were made and what challenges they must have faced. Then comes, of course, the problem of treating these children. And like Dr. Varinder, who has spent, more than 40 years serving children, thank you, sir, for your passionate service to the children and for supporting the program with your experiences all along. Which actually we have learned so much from you, and we hope to keep having your support to guide the program. With these few words, I think I'll hand over back to the team, the ECHO team under Dr. Singla's guidance, and we proceed. Thank you all, and I'm sure everybody, so I think I'll speak on everybody's behalf who learns from these experiences. So thanks to the NITRD and the director NITRD. Thanks again.
Thank you so much for your encouraging words, ma'am. And we are sure that under your leadership, we will further make this disease, will face the challenges in treating and diagnosing disease to a better way. Now, there is a pre-test link which has been shared to your registered email ID. Kindly attend. And moving on to today's presentation, today's case is from Department of Pediatrics, Lady Harding Medical College and associated Kalavati Saran Hospital. Dr. Bhanu and Dr. Kumar Vishal, senior residents at Lady Harding Medical College, will be presenting today's case. And Professor Varinder Singh and Professor Kamal Kumar Singhal will serve as the expert for today's case. Our national expert for today's case, Dr. Balaji, he couldn't join due to some urgent official work. He has to leave for a meeting. Now I request Dr. Bhanu and Dr. Vishal to please start with case presentation. Over to you.
Thank you, Dr. Urvashi, for the kind words. We at National Center of Excellence to Pediatric TB at Kalavati Saran are committed to provide the support to the program in whatever ways it is possible, and that's what is the our agenda here to discuss through pediatric TB difficulties and share with our friends in the states as to what are those challenges and how to deal with it. So for today, our team has picked up two cases. One is a pulmonary and another is an extra pulmonary. Possibility of drug resistance TB was kept. And we learn some specific areas where there can be confusion in with each of these cases. So the first case is on pulmonary TB, a case of probable pulmonary DRTB, which Dr. Vishal is going to present. So over to you, Vishal.
Thank you, sir. Thank you, ma'am. Good afternoon, everyone. I'll be presenting a case of probable drug-resistant TB. So here was a patient X who was a 14.5 years old boy who was microbiologically proven pulmonary tuberculosis, presented to the OPD after completion of 6 months of ATT in April 2024 with the following complaints. The child had complaint of cough for 1 month, which was non-productive, non-spasmodic, occurring intermittently over the duration of 1 month. No complaint of fever, no complaint of weight loss noted by parents, no complaint of lack of appetite, no complaint of abdominal pain, headache, of breathlessness on rest or exertion, and no complaint of night sweats. The present illness, the child was diagnosed as pulmonary TB on basis of microbiological evidence in November 2023. There has been appropriate response to the treatment as the child was clinically well with few days of within few days of starting treatment till recent problem, and had become and remained afebrile adequately. The child had a significant past history of Hodgkin lymphoma, which was diagnosed at the age of 3.5 years, and the treatment was completed in 2014. The child in the family history, there is no history of similar illness in family, no history of asthma in family. On examination in the OPD, the child was active and cooperative with the examination. Vitals hemodynamically, the child was stable with no signs of respiratory distress. Anthropometry was also normal for age. BMI was within normal limits. General physical examination, there was no significant lymphadenopathy, no pallor, no clubbing, no edema. In systemic examination, in respiratory examination, the child had bilateral air entry present, which was equal on both sides, but there were fine creps noted on left side. Rest of the systemic examination was within normal limits. In view of persistent cough of 1 month duration, just at the end of ATT continuation phase, in a child who was earlier clinically responding to the treatment, the following differentials were kept and the workup was accordingly planned. The first was drug resistance tuberculosis. The second, sequelae of pulmonary tuberculosis, which was likely to be bronchiectasis in this patient as per the symptom. Third, other possible tropical infections. Meanwhile, ATT was continued and the child was given symptomatic therapy. As we can see in the image here, we can see that compared to the initial chest X-ray, there has been significant parenchymal clearance with the evidence of fibrotic bands and inhomogeneous shadows in the left lower lobe, particularly in the retrocardiac area. In the CCT chest, the child had left lower lobe bronchiectasis, left lower lobe consolidation, bronchial wall thickening, and few centrally lobular nodules showing tree in bud appearance. Then subsequent to the CCT chest, the child underwent bronchoscopy, in which the procedural findings were the presence of thin secretions and edematous inflamed mucosa and ectatic changes in the left lingular and left lower lobe bronchus. And in the bronchoscopy, the samples for the relevant etiology was sent. The sample was sent for BAL for CBNAT and MJIT. CBNAT came to be MTB detected, which was 60 colony forming units per ml, and rifampicin resistance was indeterminate. Then how to proceed further? We noticed that the CBNAT was still detecting Mycobacterium tuberculosis, and there was no evidence of rifampicin resistance. We were stuck with the questions that whether the child was had active disease or not. Since later to that, the BAL MJIT came out to be negative. So we concluded that since the child had isolated symptom of cough and there was no fever, no loss of appetite, no complaint of poor appetite, weight gain that was adequate. In view of this scenario, and there was no the BAL MJIT came out to be negative, we thought that the child was unlikely to be active tuberculosis, and hence the ATT was discontinued and the child was kept in regular follow-up. On regular follow-up, the child is doing well on supportive therapy. There were no fresh issues. Chest X-ray on 6th August 2024 shows continuing further clearance, and the final impression was that the child had bronchiectasis, which was a sequelae of tuberculosis.
So what we learned from this particular case was that the child who has already been started on anti-tubercular therapy and referred to us as presumed drug-resistant TB. So when the child came to us, the constitutional symptoms had resolved. He was not running fever. He was otherwise gaining weight, otherwise active alert, and was an isolated cough, which was scanty sputum at that time. So, given the overall clinical scenario, the possibility of a drug-resistant or persistent TB seemed less likely given the absence of all constitutional symptoms. But at the same time, the treatment was continued and an effort was made again to look for a microbiological evidence. And in that process, CB0 came positive, despite the fact that CB0 was positive, because the overall clinical scenario did not make a drug-resistant TB likely. We continued ATT, but we waited for the culture. And once the culture was negative, we were more sure of the diagnosis, and we started with the primary treatment in this child, which is appropriate postural drainage, chest physiotherapy, and it is all because there is a damaged airway, which results in the difficulty of clearing sputum in that part. So what happens is these children get repeated bacterial infections probably, and just because of that stuck up mucus. And if suppose you are clearing this mucus well with appropriate chest physiotherapy, this is what the primary treatment in such children is. So this is what we learn from this particular case.
So the issues which came up in this particular patient was that a child on treatment for TB starts showing symptoms again. As Dr. Vishal pointed out, if you have ruled out any issues related to the regimen or drug dosage, then what possibilities will come? Is it a fall and rise phenomenon that you are getting a drug-resistant bacilli in a heteroresistant now coming up, and therefore the symptoms have come back? Could be one thing. The other thing could have been a secondary infection, either in the pulmonary system or outside, any other tropical infection, which would have been more substantiated if the patient had fever, child had more cough than fever. And the third possibility was it's a sequelae, and cough is part of that because of any intercurrent viral infection or something, it got precipitated and witches. However, of all these possibilities, the most sinister one is it drug resistant TB? So the commonest thing you do in this situation is that one would go for a CB-NAT. How do you deal with this CB-NAT? A CB-NAT which comes positive in a follow-up case could be from a dead bacilli also. So it does not tell us activity. And that's an important point for us to remember. But if CB-NAT is not going to provide us answer, why did we do a CB-NAT? We did a CB-NAT because that's a rapid way of confirming if there has been an emergence of drug resistance. So we could have identified at least rifampicin resistance immediately. So that was the purpose for doing CB-NAT. Having got a low positivity and nothing else to suggest the symptoms, we decided to continue the current therapy, and the child improved with supportive therapy, and subsequent culture was sent which came negative, which showed that there was a disease quiescence, and therefore this CB-NAT did not have to be given more weightage other than looking for rapid detection of resistance. So the question which often would stay with the clinician is, how long does this CB-NAT remain positivity? You see, we also always carry a burden of the past. So in the past, it was the smear which was seen. Smear, if it remained positive, it was taken as a marker of continued activity. Then we realized that sometimes even dead bacilli was seen, but DNA or nucleic acid related tests, because of their sheer sensitivity, can stay positive even in a properly treated and responsive patient. So, Vishal, why don't you share with the group as to what does the literature says, how far and how long does the CB-NAT persist even after a child who's responsive or a patient who is responsive to treatment? I do realize that most of these studies have been done in adults and not in children, but that does allow us to understand how long the CB-NAT can stay positive and how that has to be used for our clinical decisions. So over to you again.
Thank you, sir. But there are some questions in the chat. Can we take them so that,
Sure, absolutely.
So we have two questions. One says that how do you explain the X-ray findings that you have in the lower lobe? And the other one is there's a comment which says that the possibility sample and the amount of bacteria that you've got should be considered as significant.
So first, it's the radiology. So what we see here is a damage to the airway which has happened, and this would persist. It would persist for long. So as I said, if you compare the two X-rays. We'll just present them again. In the X-ray on the left side, you can see there is a opacity also on the left lower zone. But as you move to the right side, the parenchymal opacity is gone, and what we have now is dilated, well-defined airways. So these well-defined dilated airways are kind of as say bronchiectasis is irreversible. So for what we can say is that this dilatation is not going to go off anytime soon. And so whenever you do a radiograph, you will see these dilated airways. And if suppose the chest physiotherapy is not being done appropriately in such children, there is always a risk that it will get infected, and you can have in between infections also, which can mean a bacterial infection, which can predispose to which can be a viral infection. So radiology alone will not help us define whether it is an active disease or a quiescent disease given in this particular scenario. So we should not be chasing shadows only. We should be looking at the patient as a whole. So we should holistically assess the patient rather than go localize into that.
So the two things which are equally important in this child is that this child was initially responding to therapy. He had improved. He has
Yes.
gained weight. His weight has become normal. His sputum has it's a later recent time that the sputum has started coming off, has started coming up. And when we look at the other signs of activity which were not there, and that is essentially the point we are trying to make, that in these situations the CBNAT may be falsely positive. However, we do it to see whether there is an emergence of resistance. That's the only reason why we do it, which was not seen in this child. Then the second possibility could have been it's an active disease, but it is a non-rifampicin resistance. However, clinically, the child responded to supportive therapy because the alternative diagnosis was a secondary infection. So he responded to supportive therapy, continuing the same ATT. And our MDIT came negative, which says that okay, the diagnosis of this being a sickly was correct. But it is just not the diagnosis, it is the process which is very important for everyone to understand. That we did not stop therapy till the culture came negative. Because if had we got the culture, we would have also realized if the culture is positive, it is an active disease. If it is an active disease, then we would have also known what non-rifampicin resistance are there by going further. So those were the two advantages of sending a culture earlier on, keeping the child under follow-up. However, the same child deteriorates, starts losing weight, gets a fever also, and your antibiotics have not made a change, could be a probable DRTB. That is where you would have gone more invasive. Look at if you can get the second line expert or something else to help you with drug resistance. So this is why we did not think. The second question, Dr. Kamal.
So
Sir, before you take the second question, Dr. Ankur, who had asked this question, has his hand raised.
Yeah.
So, yes, Dr. Ankur, your concern, please.
Thank you, ma'am. Sir, my question is, we do not get the CBNAT report as in a form of colony forming unit per ml. We get the report as high, MTB detected high or low. So my first question is, what is the cutoff in terms of colony forming unit, which is considered as low MTB? And second question is, if this patient comes R resistance, would you consider this patient as a probable DRTB where he's recovering, he's clinically improving on HRZD if it comes R resistance? And what is the cutoff for the when you say it is MTB detected low? Because in those cases, guidelines guide us that we should repeat the CBNAT before jumping upon the DRTB regime. Thank you.
Very important point. So let me respond to them. First of all, when we say low, this was not chip-based, cartridge-based NAS. It was chip-based NAT. So this was true NAT, and that is where these CFU were given by them. CBNAT expert gives you semi-quantitative results, and they are like, as you rightly mentioned, low, very low. And it's when you have very low in a child where you're not considering your pre-test probability for rifampicin is low, and you get ref resistance, you would have to repeat. I totally agree with you. On the other hand, if your child was deteriorating and the reason you got it done was that there is ref resistance, then you will even consider that very low. At the same time, send another specimen to see whether it is on a second specimen also by a preferably by a different NAT. You are able to detect a ref resistance, and you will send your cultures where they will come positive in possibly come positive later in time, and which will help you resolve. So in a new case, it's not low, it's very low CVNAT where you have to repeat. It is not for low, it is for very low. So remember that. When we say what is very low, it's usually less than 1000, count of less than 1000. If you're using an ultra in the private sector, in government sector, we do not have ultra, then it is a trace result where RIF is not is considered indeterminate. So that's my answer to Dr. Ram.
So I have a small query, like the CVNet result which you have shown, it's shown MTV directed with 68 colony forming unit and this registers indeterminate. So how, because if the patient would have been some other hand, they would have taken it as a resistance also might have started on DRTB treatment also.
So RIF indeterminate means that the test cannot tell you whether it is resistance or sensitive. We often confuse indeterminate with intermediate sensitivity as it is reported for pyogenic organisms.
Right, right.
It simply means the test is not able to tell you either way, and you cannot construe this as a possible DRTB. You have to repeat the test, look at other clues to sort it out.
So for the benefit of audience, we have Dr. Ritu from NITRD, and I think she can throw some light on how to interpret such results when it comes indeterminate or.
And you have Dr. Urvashi. DDG TV has to be a very complete.
We have Dr. Urvashi.
Microbiologist. I mean, we learned a lot of these things from microbiology tricks from her. So we have the right person right at the top.
So I couldn't courage to ask her for this question because it's such a like 4 heads, I think, peanuts.
Sure, please.
So Dr. Urvashi, can you please throw some light on it?
Yeah, thank you so much, sir. Thanks. Yeah. So I think this debate, and I think the very choice of the case is important for everybody's learning. So the few things that sir has already explained, and I can possibly try and explain further, that lower the number of bacteria, more difficult to actually detect resistance, because in real-time PCR, we are looking for mutations which are leading to resistance. And the principle is often that the probe has to bind to that mutation. We are basing our detection of resistance on a molecular interaction where a defined probe binds to the mutated site, or a wild type probe fails to bind. Basically, we say a mutation is present based on interaction at a very minuscule or a molecular level. Hence, the number of bacteria can affect our detection. So, like sir said very correctly, even the WHO algorithm, which I'll try and share with everybody on this, if I can manage to, clearly states when the bacterial load is very low, we will get, we can get indeterminate. But few cases, in fact, this question has been asked by Dr. Rupak Singla at NITRD meeting earlier, that in the private sector, often resistance is being reported when the bacterial load was very low, which is incorrect. Because of the science that I tried to explain, we are basing our detection of resistance only on probe binding. So lesser the number of bacteria or lesser the number of DNA, the probe will fail to bind because of paucity of DNA, and not because the mutation is present and complementarity is absent. Hence, the guidelines, WHO guidelines for CVNAT clearly state very low, not to conclude resistance as resistance, not, of course, indeterminate, cannot be reported or taken for the sake of treatment. Hence, I must compliment the Dr. Ankur, who brought up this question also. So I'm happy to see that this information is, available to our experts as well. But I also, like I said, I compliment the choice of case, because Maybe those who are not really aware of these logistics, these details, will be more careful. So very low, do not take resistance as the final answer. Always repeat. Very low, low, in fact, traces, again, the same story. One has to be careful in inferring the resistance. The other thing that Sir has already clarified, I'll just again go to the molecular explanation. The DNA can be picked up by a molecular test even when the organism is no longer live, because till such time that the macrophages can actually do away with the whole organism, and so much so that the DNA should also be, broken down. And so we are only picking a nucleic acid. Had it been a messenger RNA based test, we will only pick up live bacteria, while DNA can pick up live, dead, latent bacteria, any of this. So it cannot be a good prognostic test, the detection of DNA, but Sir has already highlighted why they did it. Accumulation of resistance. One third point I would just like to add here is heteroresistance. Sir already mentioned heteroresistance can be present at the time of diagnosis. Heteroresistance is nothing. It looks like a big word. It's just a mixture of bacteria. So our phenotypic tests have a cutoff of 1%, as 1% of all the bacteria present in a cavity. For example, if 1% of them are resistant, we call the infecting strain or the patient as resistant to, for example, rifampicin. While in the case of molecular tests, we have actually achieved quite a bit, but we have not been able to go down to 1%. We still have to have, for example, if I give an example of a mutation, which is the most common RIF resistance mutation in RPOB, that is the 531 site. If the resistance is present in 60% of the colony forming units, then this particular mutation is picked up by gene expert and called resistance. Hence, accumulation of resistance from a heteroresistant colony forming units at the beginning of treatment can happen while the patient is on treatment. Hence, Sir explained that while on treatment, if a person, if a child or an adult is failing on treatment, we must always look for accumulation of resistance, because that will affect how we treat this patient. So thank you so much for the patient listening. I know it was a long answer, and thank you, Sir, for having me answer
it
this.
was
Thank
it was the answer we needed. So thank you for clarifying. So if the chair permits, can we go further with the few slides on?
So there are two questions still unanswered in the chat box. How long is TB-NAT positive in children once they have completed the treatment? That you are going to answer, as you said. And there's one, the role of NGS, and is it going to come in the program?
Well, NGS question I'll leave for the last for Dr. Urvashi to handle at the end of the second case. And the second answer, how long it can persist, we are answering now.
Thank you, sir. There have been, now we move on to the studies which have been done on false positive expert MTB in treated patients. Most of the studies which we found were done on adults. The first study was done in Cape Town, South Africa, in which adults from April 2015 to 2016, irrespective of presence of symptoms, were selected, and 262 patients were recruited, out of which 16 came out to be false positive. It was noted that the false positive patients had lower bacillary burden, increased likelihood of chest X-ray would not be suggestive of active disease, and less viscous sputum.
So these were the patients who had been treated in the past, declared cured, and they got to them after a gap of few months, and irrespective whether they were symptomatic or not, they tested them, and 6% of them came out to be positive. So that's what they, and none of these were culture positive. So that is why they were called false positive.
The key findings of the study were that the false positive results occurred in a significant minority of patients with previous tuberculosis, and the expert positive culture negative patients remained healthy or had minimal symptoms and were consistently culture negative without treatment. Although the characteristics of false positive patients differ significantly from true positive, these characteristics have a poor predictive capability of identifying patients likely to be false positive. Expert positive results in previously treated patients were transient, and about half transitioned to expert negative results after later retesting.
So what this sums up is that clinical prediction, whether this is a false positive or a true positive, is difficult. We have to have culture to say if when it comes culture negative, then only in the light of the clinical findings and the culture negativity, you are able to say it is false positive. Purely on the presence of symptoms and a positive test, you will not be able to say either way. It has a poor predictive capacity. So we have some more studies to share.
Then another study which included 221 adult patients, and in which during the course of treatment, weekly basis till 8 weeks, and thereafter at weeks 12, 17, 22, and 26, the child, the adult patients were tested, sputum samples were taken, and the key findings of the study was that the quantitative expert MTV or RIF assay for sputum M tuberculosis DNA as a biomarker correlated well with M tuberculosis smear and culture results during anti-tuberculosis treatment. Positivity rate for sputum M tuberculosis DNA detection declined more slowly than do those with conventional sputum smear microscopy, solid culture, and liquid culture, and seemed to be linear throughout treatment.
So if you would focus on this figure, the purple thing on the top is the expert results, right? So this is where the 8 weeks, our common endpoint of intensive phase, is coming. So by that time, nearly 80% of them would be smear negative or culture negative, while only 20 or 25% of them will become expert negative. Therefore, expert as a follow-up test to decide that your patient is responding at the end of 2 months will not work, because decline in this takes far longer. Even if you reach the end of therapy, a successful end of therapy, while 3 or 4%, that's your common non-response rate, there were culture positivity, but the expert positivity was about 27%. These are adult cases with large cavitary TB. The patients with paucibacillary disease, because children have both, adolescent would have cavitary, paucibacillary disease, perhaps would not have this degree of positivity. But the index case which we shared was a large parenchymal lesion, which adolescent child who would behave like an adult. Therefore, the probability of his being positive was about 1 in 4. So that is what we learned from this study. Next.
How long after the successful expert NTB can be false positive? Another study in which prospective retesting of sputum from 238 adult patients were done, and it was noted that 229 patients came out to be culture negative, and 16 of these patients, which is about 7%, were expert false positive. The patients had a lower mycobacterial burden. The false positive patients had a lower mycobacterial burden than true positive. There was increased likelihood that an X-ray will not be compatible with active tuberculosis, and the sputum was less viscous. All expert false positive patients were clinically well without treatment after follow-up.
So this looked at patients up to 2 years after stopping therapy. So about 5 to 7% of patients remained positive, though their cultures were negative, till as long as 2 years after therapy. So that's something which is important. And people have tried to see whether your CT values would, because as your DNA load will go down, your CT values should be high. It did show that the CT value was higher in those, but compared to the true positive, but they were not able to give a definitive cutoff at which you would say that okay, this is likely true or false positive. That's because it will depend on the bacillary load. So important thing to remember is molecular tests cannot be used to assess response to therapy at 2 months. That's where they cannot be used like smear. They cannot be used to at the end of therapy, because about 1 in 4 can be positive if you have large cavitary disease. And on a retreatment also, there is a probability of some of them being false positive, though much less about 7% up to 2 years after. So there can be excretion. So you have a healthy child or a patient who has some cough, you investigate it because he had TB in the past. Just because test has come positive, it may not necessarily be positive because of activity. Look at all the components, including the culture to make your final call. So
So break in between, but I think we are having positive timing and we have one more case to discuss. So can we cut down on the discussion part? Just a request.
we have finished discussion. We will.
It's already one case go. Okay, sir. Can we move on to the second case?
Yes, we will. We will.
So by the time you put the second case, my only concern in this case is कि ऐसा patient जिसके पास X-ray shadow है and जिसके पास एक gene expert में MTB detected report है, they will eventually go to some other place for opinion. या उनको ये लगता है कि हमें एक दूसरे डॉक्टर को ये बताना नहीं चाहिए about previous history of ATT. If they just don't tell the history, this patient would definitely be put on treatment. So this is for our DTOs who are attending, because invariably it happens in the field that patient will not give the complete history. They will just show you the X-ray and report, and we will miss the cases like this.
I agree with you. I agree with you. So let's quickly look at the second case where we have much less discussion. So it will be faster.
Good afternoon, everyone. Now I'm going to present a case.
Dr. Bhanu will be present.
I'm presenting a case where there is diagnostic challenge in a probable DRTB case. Six-year female of weight 17 kg came with complaint of painless swelling over lower back for 1 month. History of weight loss was present. She also had a history of fall from bed 2 months back, but had no immediate issues after the fall. There is no history of fever, cough, loss of appetite, and weight loss. On contact history, grandmother has pulmonary TB, passed away 1 year ago. Vitals and examination of the patient as per the reports, general condition fair and vitals was stable. On examination, there is a gibbous over the spine, lumbar spine, and systemic examination was normal. On imaging, in X-ray, there is kyphoscoliosis and there is decreased intervertebral disc space between D2 and L1, and there is sclerosis in the lumbar vertebra. And lungs, the parenchymal fields were normal. On MRI, there is vertebral body showing destruction, D2 L1, and paravertebral fluid collection is there. And there is no spinal cord compression. Based on these findings, we started patient on drug-sensitive TB regimen, and easy access to relevant specimen was not feasible at this time. The course of illness, at the time of presentation, there is swelling over the lumbar region. 1 month after treatment initiation, the child has new lesion in the paraspinal region. And the patient consulted another private hospital for further management, and following investigations were done. And needle aspiration done from the new swelling under ultrasound guidance. The pus was aspirated and sent for Mycobacterium tuberculosis testing to a private lab to check for drug resistance. And the report of TB expert NAT was MTB detected and isoniazid and resistance both are detected. Based on this result and contact history, patient was diagnosed as drug resistance TB and patient referred to our hospital for further review and management of drug resistant TB. The case was reviewed. At the time of presentation, there was single swelling over the lumbar spine. After 1 month, a new lesion was appeared. But there was no systemic symptoms and child was clinically doing better. What should be done in these scenarios and what should we look after these things? Any child who is on already treatment and new lesion was developed during the course of treatment, what should we look after? These are the things we should look after. Therapy related and disease related. In therapy related, we should look for the dose, whether the child is taking appropriate dose or not, as the child is taking. The child is adherence is good, taking medicine daily, and absorption is good. There is no vomiting, no gastritis, or no diarrhea, and the child has good oral acceptance and taking the medication daily. We should look after the causes of disease related also for not responding. Is the child or adolescent living with HIV? This patient HIV is non-reactive. Is the child is malnourished? No, this child is nutritional status is normal. Is there a reason to suspect drug-resistant TB in this case? The documents of the index case could not be verified as the index case was died and the documents were not saved after the death of the index case. Is there a reason for the illness other than addition for TB? There is no. How will you proceed next? Can anyone text in the chat box? How will you proceed next in this case? We done repeat aspiration and sample was sent to an approved NAT and MGIT. Points to note in this case, the test was done on TB expert, which was not accredited by NTEP or WHO and gave result RIF resistance and INH resistance detected. Remember, gene expert test, which was accredited by NTEP, will show gives MTB and RIF resistance status only. We did fresh imaging investigations undertaken and tracking of paravertebral pus collection was confirmed and pus aspiration repeated and sent for approved lab for testing and NAT shows MTB detected and RIF resistance not detected and the second specimen sample was sent for MGIT and first line and second line probe assay. On checking for epidemiological risk factors, the grandmother had passed away within 1 month of being diagnosed with TB. She had no history of prolonged or interrupted treatment. Our lab reports were accessed as the index case. The investigation was done in a NTP approved lab. We accessed her reports through her phone number by using her NICSHA ID and she has drug sensitive TB. Now we have two discordant reports. We have taken WHO approved test and we continued the treatment of this child. These are the steps we did. The unapproved test report which was done outside was ignored and no risk factors were identified for drug resistance TB and aspiration of cold abscess was done to remove as much as pus as possible and samples are sent for MTB, MGIT culture for further confirmation and patient continued to be treated as drug sensitive TB. We ruled that the apparent new lesion was due to tracking of pus and not due to non-response or drug resistance as there was no continued or fresh systemic symptoms and child was improving symptomatically. Drug resistance was ruled out using an approved test. The family was counseled and agreed with decision and for regular close follow-up. On subsequent follow-up, child doing well after pus aspiration to dry and continued drug sensitive TB treatment. Her abscess has decreased on imaging and she had gained weight too and her MGIT report shows no growth. At referral, the child has the swelling. After 4 months of ATP, the paravertebral collection was decreased. Learnings from this case was there will be error in the diagnosis due to non-approved test. In this case, initially non-NTEP approved test was taken, which was an erroneous drug-resistant TB report. And beware of similar surrounding names like expert MTB and TB expert as we see daily. It is important to find details of any source and index case. In this case, the grandmother has pulmonary TB and expired records were thrown, but data is accessed as it was registered through NICSHA. Thank you.
So this is our second case. This doesn't require much discussion other than that just as you have Nike and Nuke, you also have expert. And if we are not careful, what alarmed us was that we know expert will only give us RIF. And this one came with RIF and INH. But this one had gone through several organizations, including a major TB hospital belonging to NTB before was referred to us. This child has come to us only for writing the right prescription and dosages. So somewhere in the system, we forgot what expert is about and we forgot that R and H together do not come. So we just wanted to highlight that. Many of these tests are available when they are not approved. Thank you.
Thank you so much. You've highlighted the very much importance of getting a test done for my NTP accredited lab, because I think in daily we all are facing such issues. Patient has been started on TB treatment. Actually, they are on the basis of a report which was not done at an accredited lab.
I think it's accredited test which is more important. We would have patient going to private labs. The test should be accredited. This is
Right.
a test we do not know where it came from. So that I think is the key point.
Right, sir. So the house is open for questions. Any questions from the audiences? So we have. So, yes.
Can I just add to what Sir said that,
Very
for
fine.
example, I have shared the WHO algorithm, link to the WHO algorithm, where it is clearly highlighted that when lower bacterial load is there, you're not supposed to conclude RIF resistance, even if the machine reports RIF resistance. Secondly, if there is indeterminate or resistance with low or very low, you need to repeat the test with a fresh sample. So, of course, when the extrapulmonary sites are involved, repeating a sample is not easy or not convenient to sample again. But this is the algorithm and the science behind it. Sir has discussed at length, and I have added to that.
Thank you so much.
I have come across, no, I'll just one last bit, where private labs continue to report resistance when the bacillary load is low. So the clinicians and the all even the DTOs or any medical officer who's treating a patient should always question the lab which is making such a report and ask for a repeat test and not start resistance treatment when the bacillary load is very less. And for those who'd like to learn more, the algorithm link is copied on the chat. Thank you.
Thank you so much for sharing the links. In fact, both the cases, they show the importance of clinical judgment over the investigation radiological test. So our clinical judgment definitely should be prioritized while treating such patients and over the. Dr. Alok, you want to?
Yes.
One of the questions
Can
in
I
the-
just interrupt in between? I'm Dr. Shikha Malik from Bhopal AIMS.
Good
Good afternoon, everyone. This is absolutely the case which follows actually that the child is on treatment and then they come with another soiling. So very rightly said, that could be just the pus which has, tracked down. And of course, one has to make very clear the PGs and the residents that if the child is doing clinically well, is eating well, I think we should wait for the treatment, for the medicines to show their result before we start considering any other resistant organism, which is very, very common thing to happen if they visit other places. And secondly, sir, one case which I would like to share here, because there was a patient called Humayu, which came in 2018 or 19, and we got the CB test done and it came positive. The child had pulmonary tuberculosis. But what happened even after starting ATT, the child continued having high grade fever for almost 1.5 months, like 100, 200, 300.5. And we did all the possible tests which we could see or for any resistance, and every time it was a sensitive thing. So then when we searched the literature, we got to know that sometimes what happens in such chronic illnesses, because of the body being always subjected to inflammatory leukins and interleukins, the temperature is set at a very high level in the hypothalamus and the pituitaries. And what happens is that this takes a lot of time to come to normal. So just see, because otherwise he was playful, he was eating well, he was even in his weight was increasing. But the only problem during the ATT when we were giving was 100, 200, 300, 3.5, which we documented, and we kept him in AIMS for almost 1.5 to 2 months. But ultimately decided that we should continue with the treatment because the child was doing well, his weight was increasing, and then literally after a month and a half the temperature became normal. So that is sometimes that we have to see also if the child is doing clinically well. Thank you so much for the patient hearing.
Thank you so much for sharing your experience, ma'am. Just a request to the audiences, post test link has been shared in your registered email ID. Please attempt that. Dr. Alok,
There are a couple of questions which are there in the chat box.
so we'll take them also.
Sir, one is about steroid need in pot spine. So we do not use steroids unless until there is a compression symptom or neurological deficit. This child did not have any of those. There was neither an spinal collection whatever collection was there, it was paravertebral, it was not intraspinal. So if there is no compression, no edema inside, then steroids are not recommended. With respect to Dr. Shikha's sharing her case, thank you very much for sharing your experience. What is important is that we have to create that experience also. So if a child is not doing well, the whole checklist stays with in every patient. We cannot either say that it will take longer. If it is not following the routine, we have to look for whether it is drug resistance, whether it is a non-adherence to therapy, or it's a wrong dose, or it's an alternative thing, or something like what you have alluded to. So thank you for bringing it up. Dr. Alok, please carry on.
Thank you very much, sir. Good afternoon, sir.
Good afternoon.
And Kamal. So both the cases are very well presented, and it's always a learning experience to hear you in the cases of TB related cases. Sir, my question is regarding the POTS spine cases, TB spine cases. Actually, I just want to know, as the steroid you had already one question, you already give the reply of that particular question. My question is that how long the treatment of the TB spine cases? In the literature, some literature said the treatment duration is of 6 months and 12 months is as 6 months and 9 months is as equal as 12 months. So, sir, what is the treatment duration of these cases and how we follow up of these cases? As the paraspinal abscess, it subsides due course of the time after giving the TB treatment. So, how you follow up of these cases? And at which time we stop the TB treatment in these cases?
So while there are some studies which have shown 6 or 9 months therapy, but as till date, we are using 12 months therapy under the program for all bony involvement, particularly POTS spine and TBM. So that stays because of the lack of enough evidence either way. So in fact, our friends in orthopedics often tend to give it longer than 12 months. They want to give it for 1.5 years. I think that's an overkill. Possibly there may be a possibility of further reduction. The trouble is that we do not have so many cases to say that a lower duration would work, but there are some studies, as you rightly alluded to, but at the present time guideline says 12 months. Usually if you see pus which is tracking to the surface, if it is not removed, it will rupture, it will cause damage, it will cause fever. So pus anywhere which is reachable should be drained. Even if you find large psoas abscesses, if you don't drain them, 3 or 4 months later, you will find this coming down into the femoral area and creating swelling there. And then we'll say, oh, it is a femoral lymph node which has separated, a new lesion at a new area, therefore it is drug resistance. Same thing was happening with the case which we presented. It tracked down to the periphery, it looked like a cold abscess in the parietal. When we looked at the MRI, it was continuity of the paravertebral abscess. So the pus, if it is not drying off by therapy, because it's already liquefied and that's where your drugs will not reach, it will find its way out somewhere or the other. And if it can be removed easily, it should be. But a word of caution here is, sometimes people, out of being overzealous approach, would try to reach a psoas abscess directly through ultrasound guided through the abdomen. Don't do that. It's a retroperitoneal structure. We have to go retroperitoneally. Use help of an orthopedician. So we also have had this difficulty where there has been seeding into the peritoneum. Usually because they are on therapy, it does not cause a damage, but it can. More so if it is drug resistant. So it is not recommended that it should be drained anteriorly. It should always be drained from the retroperitoneal area. Anterior drainage happens if only it is already tracked to the femoral area.
Thank you so much, sir, for the detailed explanation. And due to paucity of time, I think we should end this clinic. And for the closing remarks, I would like to call Dr. Ashok Bhardwaj, sir, for his closing remarks.
So thank you, Nita. So I did not get the information. So Shifa told me. So thank you. But it was a wonderful case. I heard from Dr. Vrinder Singh. So my positive point is that this clinic has picked up. So today also about 180-90 people had joined. So hopefully this clinic will also flourish and hopefully all pediatricians will join this clinic. So thank you very much, Nita. Thank you for giving me a chance. Thank you.
Thank you, sir.
I think what we need is for this clinic to flourish is we should start getting cases from our DTOs, from our STOs, from other.
Yes, yes, sir. Yes, yes, sir. Yes.
So even if those may not be so very difficult for others, if you have faced a problem, that means there is a problem. There are people who are thinking like you. So that problem has to be resolved. There is no question of, what is difficult for me may be handled at a different level. What may be difficult for someone else who is fresh into this business would be at a different level. But all the same, for a proper delivery to the patient, all of these difficulties are important. Therefore, we need to have those cases. Thank you.
Rightly pointed, sir, because they are the one who are facing these cases more, and they are the target population. And for this clinic also, our target is mostly the DTO, so that they are able to manage these cases at the peripheral level, and only complicated cases reaches to us. So that is the even aim of this clinic, the knowledge dissemination through this clinic. So DTO should be encouraged further to present their cases, and thank you so much for sharing such practical cases in this clinic, and they are the cases which we face daily, and it brings a lot of discussion to it. And anything else, ma'am?
Yeah,
Thank you, ma'am.
Saroj?
Yes, ma'am.
Yeah. So I just like to say in the end, we had very good case presentations and nice discussions also. And I would like to also thank Dr. Neeta for continued efforts for coordinating these sessions. And as suggested by Dr. Virender, like we can have inputs from cases from DTOs and STOs. So that will be very helpful. Thank you.
Yes, ma'am. And to further improve this clinic, we need your feedback. So please, feedback form has been shared in the chat box and to your registered email IDs also. So please give your feedback where we can improve further and make this clinic more learning experience and expertise. And with this, I would like to say thanks to the team of Lady Hardy Medical
Would just
College.
like to, can I just add something here, please?
Yes,
Since
ma'am.
we are requesting DTOs to share their experiences,
Yes.
in case they face any issues while treating patients, is there a forum where they can approach experts like Varinder sir or
They can
you know,
always
if
write.
adult physicians DR? No, is there a formal channel that they can write to?
Yes, ma'am. There is a formal group that has been constituted by Central TB Division. There is a specific email ID that has also been given. And the cases first have to go to their nodal DRTB centers, and the nodal DRTB center will refer the cases to Central TB Division to Dr. Sandeep Chauhan. And at
So
the
that I'm aware of. That I'm aware of. I was talking about, for example, the pediatric difficult cases. You know, children need special treatment. Special treatment, I mean, special care. So if they're having any issues with diagnosis, we could have a pediatric.
we have 4 pediatricians on that panel.
I'm sorry?
We have
I am not only concerned about DRTB, I'm also concerned about DSTB, like what sir presented earlier was a DSTB case. So do we have something for difficult cases as well? I mean, we can, if not, we can have something. If we have, then make it more public, just, you know, so that expert guidance can be given where required.
So
Thank
maybe
you.
we can create another group for pediatric cases alone, which may not necessarily be DRTB on the same lines. That could be one answer. But one thing more, Dr. Urvashi, which I thought is important to bring up here, flag here, is the availability of WHO or NTP non-approved tests, which have not been verified. Can we write to DCGI and the labs? And the other thing you talked about, RIF resistance being reported when it should not be reported by the labs. Through the forum of DCGI, program could write to them, and if they could, write to the labs or NABL, possibly those changes would come and there will be less mistakes. So please think along those lines if anything can be done.
Ji sir, absolutely. This was one of the things on my mind to actually, probably spread the, educate about the guidelines and what should or should not be done. So as rightly suggested by you, we can write to NABL that certain guidelines have to be followed. Otherwise, this is misreporting. We'd be reporting MDR much higher than what it actually is. So that is going to create more problem than help.
Or
So
even
yes,
if the lab has to write, this is not a test approved by NTB, no, as a disclaimer. At least that highlights to the average clinician that this is some other test which is coming.
absolutely, sir. Scientifically incorrect is a term I would like to use rather than, I mean, for the statements like where the report resistance and low or very low, those are scientifically incorrect. But yes, I'll try to take care of all your suggestions.
Urvashi ma'am, just one thing I'd like to just add on regarding NABL. Ma'am, most of the assessors in NABL are not very well trained lab people regarding TB. So that's another challenge to be faced and really to be looked into. So that's why probably they are themselves making the error when they're going to audit the other labs. That's all I need to say. Thank you, ma'am.
So Dr. Ritu, we could possibly, write to them that these are the errors that we have come to know of from NABL accredited labs. If you come across any further errors, kindly share that with us so it can be a composite letter that we write to NABL to take care of these.
Yes,
of
ma'am.
course, their
Thank you.
choice of experts we can have little influence on. And it's practically not possible for all pathologists or all microbiologists to know all the caveats of all the infectious diseases. So we have to keep on adding our bit where we find there are errors happening. Thank you for highlighting this.
Thank you so much, ma'am. So to sum up the clinic, I'll just say 2-3 points. The CBNet should not be considered cautious, should be read cautiously when we are treating a patient at the end of the treatment, and when there is a clinical improvement is there. And the accredited test should be considered while making a diagnosis of DRTB in such patients. And importance of contact tracing and knowing the details of the contact tracing through NICSHA ID is very much important, and we all we have access to NICSHA ID. So these were the main highlights of today's two cases. And with this, we would like to end this clinic. And with big thanks to Dr. Varinder sir's team from Lady Hardinge Medical College and Kalavati Saran Hospital.
I thank both my senior resident and Professor Singhal for having worked hard on these cases, and that was fantastic. But Dr. Urvashi, yes, this was something which didn't get highlighted as much. That a lot of help was given to us by the fact that we could go to the NICSHA through that. Only thing available to us was the contact number. As it happens, the moment a person dies, they throw away all their medical records. So we weren't sure. One of the proxy index for drug resistance is a person dying of TB. So we would have been in a bigger dilemma for the first child if we had not received anything. So that also helped. So e-registration is something which is very, very useful. Thank you. Thank you.
Thank you, sir. And
thank you, sir. We'll convey that to the team who works very hard. And I would reiterate that all the experts, like you, the other members also, any guidance they can give for improvement, we are happy to actually continue to improve. Thank you so much.
Thank you so much, ma'am, for joining us throughout the session and giving your valuable inputs to us. And this is actually encouraging for our program, and it gives strength to us also to continue doing more and more work towards ending tuberculosis from our country. And with this, thank you so much. Have a great evening, and thank you.
Thank you, Team NITRD, for giving us this opportunity. Thank you.
So the session will continue to run for another 2 minutes. So please give your valuable feedback. And the next upcoming pediatric TB Eco Clinic will be on 17th of September. The case will be presented by Dr. Amber Kumar from AIIMS Bhopal.